get started because we got a lot to get through. So my name's Anna. This presentation is called Neurology and the Role of the Speech Language Pathologist. I'm happy to be here tonight and talk about one of the most, I'm so passionate about this part of our field and working with patients with neurogenic disorders. And kind of my goal for y'all tonight is to kind of walk out of this presentation feeling more comfortable, confident, assessing and treating patients with neurogenic disorders. So let's get to it. Disclosures, financial disclosures. I do receive payment from Tim's University, Tim's Medical for this presentation. I'm employed as an SLP at Emory Healthcare in Atlanta, Georgia, which is not at all affiliated with this presentation. Non-financial disclosures. I'm a member of ASHA. I'm a certified brain injury specialist through the Brain Injury Association of America. I have a certificate in neuroscience via Coursera, and I am a user of Tim's equipment. We use it for both our modified barium swallow studies and our fees, and it's great. It's excellent. A little bit about me. I went to the University of Georgia for undergraduate and graduate school. I've practiced in acute care, inpatient rehab, and outpatient rehab, and all working with adults. I'm currently in acute care, working with the adult, mostly geriatric population. Like I said, I complete both video fluoroscopy and fees. And if you haven't gathered already, I love neuroscience and neurology. And like I said, this is just a passion of mine. And it's not something that came easy. It's a really hard topic to understand. But I've just put a lot of time and effort in kind of finding the resources that can help me better understand it. And now that I have a better grasp on it, I like to kind of give that education back out to the clinicians in our field. So thanks for being here tonight. A few points that I always kind of like run through before presentations. The importance of understanding the neurology behind our work, as well as the timelines, the disease progression, the acuity or the chronicity of the disorder. So all of these things are going to impact how you go about assessment, treatment, prognosis, how you're explaining the prognosis to patients and their families. Something like ALS is going to be treated differently than something like dysphagia from an acute stroke. So understanding the neurology, in which we'll get into certain disease processes, is a very important part of working with patients with neurogenic disorders. Patients' rights and ethics and decision-making. I mean, I think this one goes without saying, and I think as a field, we're pretty good about it as a whole. But, at the end of the day, the rights of the patient and their family are our primary goal of care. We can give education and thorough, education about a modified or whatever the results of our assessment are, but it is up to the patient and the family to kind of follow those recommendations or not. I mean, it's informed consent. There's no, fear mongering, and the education that we're giving is, giving them kind of the data and making them make that decision themselves. The dangers of regurgitation of information without thorough understanding. And I say this because it's, neurology and neurogenic populations is it's like I said, it's a complex topic. There's a lot that you have to really understand to process through, like what the implications are for patients that have, dysarthria, dysphagia, dysphonia. That's the result of a neurogenic process. And it's important because, when we're commenting on these things, this is going in somebody's permanent medical record. Like, this is a legal document. So it's important to be confident in what we're saying, because this is, somebody's chart, somebody's history. So for example, if I follow a clinician that sees a patient and they perform an assessment, and in their cranial nerve exam, they're talking about, they appreciate like lingual fasciculations, but that patient has a primary diagnosis of Parkinson's disease. Well, based on what we know about the pathology, like at a cellular level, what's happening in Parkinson's, we shouldn't see lingual fasciculations. We might see lingual tremors or like tremulous movements of the tongue. But unless it's something like a Parkinson's plus syndrome, like a multiple systems atrophy or PSP, we shouldn't see lingual fasciculation. So when you're putting that in somebody's chart, I mean, that's a permanent record, and we should be confident, we should be 100% sure about what we're commenting on. And if we're not, we should put it in a way that maybe we're not saying this is exactly what we see. Neurological diagnoses and kind of the connotation that comes with that. So, when I first kind of like started to kind of get into the like realm of neurology and in the field of speech pathology, my mind went to like brain, like disorders of the brain. And of course, that's a huge part of it. But neurological diagnoses, I mean, that can include anything from the spinal cord to the nerve itself, to the neuromuscular junction, the cortex, the subcortical structures. So there's a lot of things that have to be intact in order to generate all the things that we're assessing and treating when we're working with patients with neurological diagnoses. So for example, like a spinal cord injury, that's damage to the central nervous system, to the spinal cord, but the cortex might not be involved at all unless there's like a co-occurring brain injury. Or Bell's palsy. This is a neurologic disorder of the actual facial or peripheral nerve itself, but the brain or the cortex is intact. So the way I kind of explain it is just think about the like depth of what neurologists diagnose and treat, anything from the cortex to the neuromuscular junction, spinal cord, the nerves. And we're going to kind of tease apart all these pieces so that we can kind of better understand like how they all work together as well. So we'll get into neurology foundation, so like anatomy, and kind of the principles of the physiology that we're looking at when we're seeing these patients. So we have the central nervous system, which contains the brain, the brainstem, and the spinal cord. And then you have the peripheral nervous system, which contains the cranial and peripheral or spinal nerves. So there's this really quick, efficient, complex interaction happening between both of these systems in order to carry out like the simplest of movements. So I mean, just me like moving my right hand right now, that's my left upper motor neurons sending the signal along the tracks within my brain, down through my brainstem, to my spinal cord, and out from the ventral horns of my spinal cord to the nerves that innervate my arm muscles. So there's a lot that's quickly happening. And if there's damage anywhere along this pathway, that can kind of manifest as weakness or motor or sensory issues. And certainly something that we could see in patients that we're assessing and treating. And a few more terms that I'm going to throw around in the next few hours to have a good grasp on. Neurons are the cells or the cell bodies in the nervous system that generate and receive information. So they are the gray matter. So when you think about like, when you visualize the brain, you see like the pink, the grayish matter, and the white matter. This is that pink or gray matter. It's all made up of neurons. And then nuclei are groups or clusters of specialized neurons that have some type of specialized function. And again, it's gray matter because it's neurons, but it's just a cluster of them. So for example, the thalamic nuclei in the subcortex, the cranial nerve nuclei, which we're going to get into a lot in detail in a second. The basal ganglia are nuclei. So these are all like groups of neurons that have some type of specialized function in order to carry out some type of movement or sensory function or whatnot. The nerves are the white matter pathways made up of axons that send information to other parts of the brain and body, and they are in the peripheral nervous system. So if you remember from like foundations of biology or anatomy, the neuron is a cell body, and then you have axons that send that message from the neuronal cell body out to other structures in order to communicate with them. So nerves are the axons in the peripheral nervous system. So for example, the cranial nerves, the peripheral or spinal nerves. And then tracks are the white matter pathways made up of axons that send information to other parts of the brain and body, but these are the ones in the central nervous system. So like anatomically speaking, they're the same thing. They're bundles of myelinated axons that can send information. But in the central nervous system, they're called tracks. In the peripheral nervous system, they're called nerves. And it's important to differentiate these because we're going to get into a lot more in depth of those. An infarct is an area of tissue death due to inadequate blood supply and oxygenation. So, in the case of like an acute ischemic stroke, you initially have ischemia where that blood flow is not perfusing to the area, and then it turns into infarcted tissue, which is what shows up on imaging as an acute stroke. So what actually happens after an infarct is, that tissue is not getting the oxygenation and the tissue actually dies. And then there's a process called apoptosis where there's like glial cells that essentially clean up the dead tissue and fill it with scar tissue. And that's what we see that's what radiologists see on brain imaging as stroke. So there's not actually any functioning neurons there anymore. And then the internal capsule is a two-way tract in the brain that sends sensory information and motor information to and from the brain. So sends motor information from the brain to the body, and then it picks up sensory information from the environment and sends it up into the parietal lobe of the brain. So there's ascending and descending tracts in the internal capsule. So what's the sequence? What's the most important pathway when we're thinking about the innervation of the muscles of the head and the neck, the ones that we are focusing on as speech pathologists? So you have the pyramidal tracts that begin in the precentral gyrus, the motor strip, and they descend as the internal capsule. So remember, tracts are the bundles of myelinated white matter that send the information up and down. So the cortical bulbar tract is the motor tract that communicates directly with the cranial nerve nuclei and the brainstem in order to move the muscles of the head, the neck, the face. So obviously, as speech pathologists, this is the one that we want to be familiar with, because when we're assessing things like dysarthria or dysphagia, muscles that are important for that, the cortical bulbar tract is essentially how the upper motor neurons are communicating with the lower motor neurons in the brainstem. And then important to kind of just know or be familiar with, there's also the corticospinal tract that travels with the cortical bulbar tract as a bundle within that internal capsule. And the corticospinal tract is what communicates with the spinal cord in order to move the muscles of the arms, legs, the trunk. So maybe something that like physical and occupational therapists are more familiar with, but just important to know that this runs through with the cortical bulbar tract as the pyramidal tracts within the internal capsule. So the neurons of the cortical bulbar tract are the upper motor neurons, the motor strip. The cranial nerve nuclei in the brainstem are the lower motor neurons. And then the actual cranial nerves themselves are the peripheral nerves, or part of the peripheral nervous system, or the final pathway before the message, the motor message, reaches the muscles. So if you kind of recall, like from grad school or anatomy again, the motor strip, the motor homunculus, it has different names, but essentially there's different parts of the body are kind of represented on different parts of this motor strip. So some areas have more like cortical representation. Like if you can see, the muscles of the head and the neck have a good chunk of upper motor neurons. Whereas like the muscles of the lower extremities are more towards the medial motor strip. So important to be familiar with, because let's say that you have a patient who had like an ACA or an anterior cerebral artery stroke. Well, the ACA supplies more of that medial motor strip. So you might be expecting or hypothesizing that they will have primarily lower extremity weakness. Whereas a patient that's had a middle cerebral artery or an MCA stroke, that middle cerebral artery perfuses the areas of the lateral motor strip more so. So you might see, more prominent dysarthria, facial drooping, dysphonia, dysarthria, dysphagia in this population that has had some type of insult to the artery that supplies or perfuses the lateral motor strip. So back to the tracts. So the pyramidal tracts have different names depending on their location within the central nervous system. And in kind of like superficial to lower, they start as the centrum semiovale up top. Then they descend down as a corona radiata, the internal capsule. And then once the bundle of tracts kind of enters the midbrain and the brainstem, they become the cerebral peduncles. So important to know these terms, because when we're reviewing like an MRI, we're doing a chart review for a patient that had a suspected acute stroke, and the MRI brain's completed, and it was not going to say something like left cortical bulbar tract, although that would be helpful. It's going to say something like, left posterior limb of the internal capsule or left corona radiata, give a general like region or lobe, but it's not going to say the specific motor tract that is damaged, because they all run together. The cortical spinal and the cortical bulbar tract, they run as a whole bundle. But these terms are what you should really be looking out for, because if, let's say that somebody has an acute stroke in the right internal capsule, well, that could manifest as weakness. So it might be that their upper motor neurons are intact, but the white matter that communicates the message in order to send it to the rest of the body is damaged, and now that message can't get to the lower structures. So important to know that these white matter pathways, these are the axons that are communicating primarily with the brainstem and out to the muscles of the head and the neck and the body. Here's another picture of the cortical bulbar tract that I like, just because you can kind of see like how it, that like projection pathway of it. So the blue strip up at the top is the upper motor neurons and the precentral gyrus of the frontal lobe. And then the red, like fiber looking tracts, those are your cortical bulbar tracts. So those are your axons of your upper motor neurons there in the blue part of the bulbar or cranial muscles. And then as they descend, you can see they kind of go through the subcortical structures, pass through like the basal ganglia near the thalamus, ultimately reach the brainstem. And then once they reach the brainstem, they then synapse at the respective cranial nerve nuclei, which we're going to talk about in a second. And if you feel like I already lost you, we're going to go over this like several times. I'm going to revisit the same slides again. So hopefully by the end, you're a little bit more confident with it. So what's the whole, like putting the whole pathway together? What's the entire sequence of, we have to move the muscles of the head and neck. So first, the signal is generated by the upper motor neurons in the motor strip and the precentral gyrus. It's then sent along the axons of the upper motor neurons via the internal capsule or the corona radiata, centrum semiovale. Remember, it's going to have different names depending on where it is, but the cortical bulbar tracts are within this bundle. So from there, the axons will then pass through the midbrain and become the cerebral peduncles. So now we've reached the level of the midbrain at the brainstem. And then the signal will then synapse at the appropriate cranial nerve nuclei in the brainstem. So for example, if it's the upper motor neurons of the facial nerve and the facial muscles, it will synapse at the facial motor nucleus in the pons. And then from there, the motor signal or message is then sent to the muscles via the efferent or the motor branches of the cranial nerves. And those cranial nerves actually emerge from, they like branch out from the motor neurons in the nuclei and the brainstem. So obviously this is a very like complex pathway and sequence. So if you have damage or some type of compromise to any point in this sequence, that can manifest as weakness. And that's something that we will be looking for when we are consulted to assess, especially like in the acute setting or the rehab setting, patients that have been admitted with a suspected change, like a stroke. So getting into the lower motor neurons, the cranial nerve nuclei, So you have motor and sensory nuclei. So we'll talk about the motor nuclei first. Those are the lower motor neurons. These are clusters of cells or gray matter, because remember, nuclei are just clusters of neurons that grow out efferent fibers or axons that make up the cranial nerves to innervate the muscles of the head and the neck. Now, that's like a lot of big words, but simply put, you have the upper motor neurons and the motor strip. Again, that message is sent along the tracks. Synapses at the second order neurons and the lower motor nuclei in the brainstem. And then from the lower motor neurons, it goes out to the cranial nerves to reach ultimately the muscles that it's innervating. And then sensory nuclei are clusters of cells or gray matter that receive sensory information via the afferent fibers or axons of the cranial nerves. So they are, you have receptors, and then those receptors will then send the sensory information up the ascending tracks, ultimately through the brainstem, through the thalamus, and up to the brain, where it's then processed. So again, you have a sensory nerve. It is the message, the sensory information is transmitted to the nuclei, the sensory nuclei in the brainstem, goes through the thalamus, which is like a sensory processing, sensory relay center, and then ultimately reaches the somatosensory cortex in the parietal lobe. So same thing, with sensory function. If you have damage to anywhere in this sequence, this kind of a chain, you could potentially have a sensory impairment. So one of the most important things to walk out of here understanding is that most cranial nerves connect to one or two of the nuclei in the brainstem. And this is where it gets really tricky, because it would be really like straightforward if it was, facial nerve only connects to the facial motor nucleus in the pons, easy peasy. But the facial nerve also has some afferent or sensory branches that actually connect to the nucleus of the solitary tract in the medulla. And so we have different nuclei connecting to various branches of one nerve. And that's going to be really important to understand when we're trying to tease apart, what we might expect when we're, chart reviewing somebody that's had some type of neurologic deficit. So again, sensory and motor nuclei, sensory and motor function, and they're all bilateral or paired. So the left and the right have the same nuclei. And we'll get into that in a second with a picture for the visual learners. So in understanding the cranial nerve nuclei and kind of like where different nuclei are located, what is the benefit of that? Like, how does this map to clinical presentation? How is that going to help me when I'm, chart reviewing somebody or assessing somebody and trying to figure out, like lesion location, or trying to figure out, is this presentation consistent with what I know? So for example, if somebody has the MRI says, medial pontine infarct, well, based on what I know about what nuclei are there within the pons and more towards the middle, the medial pons, I might be expecting facial, like an ipsilateral facial weakness, because that's where the facial motor nucleus is. I might be expecting some like disconjugate gaze or like strabismus, because that's where the abducens nuclei that controls eye movement is. Maybe some like hypo or hypersalivation, because that's where some salivatory nuclei are. So important to understand, and you don't have to memorize it, but visually, being able to kind of tease apart, okay, this is where this is where this like group of motor neurons is, which could be important in terms of swallowing or voice or speech. So for this visual, like I said, each of these are paired, but for the purpose of this visual, I have the sensory nuclei on the left side of the brainstem and the motor nuclei on the right side. But just remember that they're all paired. It would just be way too visually distracting to have all of them. So I kind of pulled out the ones that I think as a speech pathologist are important to be familiar with. So up at the top there, you have the midbrain, and then that kind of wider part of the brainstem is the pons, and then the lower, most inferior part of the brainstem is the medulla. So like I said, facial motor nucleus is in the pons. So if somebody has an acute stroke or bleed or tumor or compression, that those lower motor neurons might not be able to then communicate with the facial motor nerves. And then what does that manifest as? Typically, if it's the entire nucleus, a hemifacial droop. So the upper and lower face will be impacted or have weakness. So for example, let's say that somebody has a midbrain stroke or some type of midbrain lesion, and that ocular motor nucleus can no longer communicate with the ocular motor nerves in order to move the muscles of the eye or support the muscles of the eye, then you might see ptosis or like eye drooping in somebody that's had an acute midbrain stroke or some type of other etiology. And then the sensory nuclei there on the left. So there's a lot of representation in terms of the trigeminal sensory nuclei, and we'll get into that in a second, but they tend to kind of span like longer distance throughout the brainstem. Like you can see the trigeminal sensory spinal nucleus like has quite a long like path of sensory nuclei. And this is, remember, if you're thinking about kind of the pathway or the sequence, those afferent or peripheral sensory nerves will be grabbing that information from the environment via receptors and then sending that information up to these sensory nuclei, from these sensory nuclei then to the thalamus, and then from the thalamus to the parietal cortex. And this is all also within the fibers that we talked about within the internal capsule also have those ascending sensory branches. So all those parts have to be intact. And we're going to revisit this picture because we'll get more into like clinical implications, and it's always helpful to kind of like see it again after you have a little bit more information. So again, cranial nerve nuclei that I think as speech pathologists we should know, and certainly speech pathologists that are working, you know, in a medical setting with a medical population. So from kind of the superior to the inferior, we'll start at the top and kind of descend through the brainstem. In the like midbrain pons junction, you have the trigeminal sensory mesencephalic nucleus. And then as you continue to descend into the pons now, so that like wider part of the brainstem, the trigeminal motor nucleus is in there, the trigeminal sensory principal nucleus, the facial motor nucleus, and the superior salivatory nucleus and inferior salivatory nucleus. So some pretty important ones when we're thinking about, you know, speech and swallowing, not only the sensory nuclei that are relaying information up to the brain and the central, you know, more of a central nervous system, but also the motor nuclei that are sending information out via the cranial nerves. And then as you continue to descend, the pons, like medulla junction where they meet, you have the nucleus of the solitary tract. The nucleus ambiguus is in the medulla. The hypoglossal nucleus is in the medulla. The dorsal motor nucleus of vagus and the spinal trigeminal nucleus are all in the medulla. So we're about to kind of look more in depth at certain cranial nerve nuclei or lower motor or sensory neurons. But before we do that, I wanted to briefly talk about the two that are starred, because this is where I tend to lose people because it's so hard to grasp this. And I'll try the best I can to explain it. So the facial motor nucleus and the hypoglossal nucleus, these are, when we're thinking about from this list, from the nuclei that we are focused on as SLPs, these are the only two that do not receive bilateral cortical innervation. And what I mean by that is all these other nuclei, they have bilateral innervation coming from both the left and the right hemisphere. So the upper motor neurons, those cortical bulbar fibers, are descending and synapsing at both nuclei in the brainstem. Whereas for the facial motor nucleus and the hypoglossal nucleus, they are only receiving, well, hypoglossal specifically is only receiving cortical bulbar communication innervation from only one hemisphere, which is why we see pretty prominent lingual deficits when somebody's had a unilateral cortical stroke. And the facial motor nucleus, the way that the nuclei are kind of laid out, the upper part of the nuclei, the motor neurons that control the upper facial muscles, they do receive bilateral cortical innervation. So both the left and the right cortical bulbar fibers are communicating with both nuclei, the upper parts of the nuclei. And then the lower part of the facial nuclei that controls, that has the motor neurons of the lower facial muscles is only receiving innervation from the opposite or contralateral hemisphere. And hear me out. I am not an artist, but I try my best because this is so hard to understand without a visual. If you're thinking about the right cortex, so, okay, let's flip because it's as if you're looking at the patient. But the right cortex or the upper motor neurons within that right motor strip, that right upper motor neurons, in red, and then the left cortical strip, motor homunculus, upper motor neurons, however you want to think about it, and the cortical bulbar tracts that attach to the motor neurons in order to communicate with the lower structures, those are there in blue. So if we zoom in really close to the pons, and we're looking at the facial motor nucleus. We have the right facial motor nucleus, the left facial motor nucleus. You can see that the right upper part of the facial motor nucleus is receiving innervation from both hemispheres. We have both hemispheres communicating via the cortical bulbar tracts or fibers with the upper part of the nucleus. Same with the left. We have both hemispheres are communicating directly with the upper part of the facial nucleus. Whereas the lower part, again, remember those are the motor neurons of the lower facial muscles. They are only receiving innervation from the contralateral hemisphere. So the left cortical bulbar fibers of the upper motor neurons of cranial nerve 7, the facial nerve, are only descending and communicating with the lower part of the right facial motor nucleus and vice versa. So this is why when somebody's had some type of impairment that affects the upper motor neurons or the tracts, that this is something that is so clinically important because it can tell us a lot about a lesion location simply by knowing this information. And something that, and we'll get into a case study, that's something that's so important when we're following patients that have had some type of neurologic insult, that we want to make sure that their presentation stays consistent with what we would expect knowing this information. So with that, we'll get into kind of when something goes wrong, what do we expect to see when something goes wrong or there's some type of compromise? So when we have upper motor neuron damage, this will be somewhere above the cranial nerve nuclei in the brainstem, and it's typically the cortex or the subcortical structures, the pathways that communicate with them. The deficit that this could lead to will depend on the innervation pattern. So like we just talked about, most of them are getting bilateral innervation from both hemispheres. So typically a unilateral cortical stroke or lesion will not cause significant impairment to the structures that are receiving bilateral innervation because there's a fail-safe. And then of course the contralateral innervation, which we talked about, the hypoglossal nucleus and the facial nucleus, motor nucleus. Like I said, clinically, these can tell us a lot because we can localize something to upper motor neuron damage or lower motor neuron damage simply by knowing the innervation pattern that we just talked about with the facial and the hypoglossal nuclei. Weakness, you're going to see weakness, and this is typically due to disuse muscle atrophy. So you might see weakness that progresses because those muscles are ultimately not getting input from the upper motor neurons. So you can see hyperreflexia, spasticity, like increased tone, and this is all because these pathways that communicate with the lower structures are damaged, and as a result, you see these like up hyper reflexes. So if you think about upper motor neuron damage, the muscle itself is intact. It's getting less input from the cortex, from the upper motor neurons and the upper motor neuron pathways, the cortical bulbar fibers, which means the muscle's getting less stimulation. So the initial pathway of the sequence is damaged. The final pathway, the nerve itself, is intact. So it's not that the cranial nerve is actually damaged. The upper motor neurons or the upper motor neuron tracts are damaged, and that because of that, the muscles aren't getting that input that they need in order to move. So lower motor neuron or actual cranial or peripheral nerve damage is somewhere at or below the cranial nerve nuclei in the brainstem, or the actual peripheral or cranial nerve itself. So these deficits will always be ipsilateral, meaning same side. So if somebody has a, let's say like a trigeminal nerve tumor sitting on their trigeminal nerve or compressing the trigeminal nerve on the left, you are going to have left trigeminal or mastication, weakness, some type of compromise that will lead to clinically what we see as impaired mastication or jaw deviation. Weakness, of course, you're going to see weakness when there's lower motor neuron or direct nerve damage. With lower motor neuron or nerve compromise, you're going to see hyporeflexia, so reduced reflexes, hypotonia, reduced tone, flaccidity, or just like flaccid muscles, you can just like completely atrophied, and fasciculations, which are essentially like misfirings of the neurons causing like twitch-like movements of the muscle. So with this, the muscle is initially intact. Even when the cortex sends the message, that motor message can no longer reach the muscle efficiently because the final pathway is damaged, whether that's the nerve itself or the lower motor neurons in the brainstem. That message if you think about the sequence, the order of events, that message can no longer get to the muscle, which is the ultimate endpoint or goal. And when that happens, we then have significant weakness or atrophy because those muscles are not getting any stimulation. So we're going to get into diagnostics and the cranial nerve exam. So I pulled out the cranial nerves that I think are most important for speech pathologists. So we're going to kind of walk through the functions of those, and then we'll talk a little bit about the connections they have within the brainstem, and then we'll go into completing the actual cranial nerve exam. So first off, we'll talk about the trigeminal nerve, the fifth cranial nerve. It has both afferent or sensory branches and efferent or motor branches. So sensory-wise, it controls the sensation of the intraoral cavity, the facial sensation, and sinus cavity. Motor branches to control mandibular movement. It also has a small role in velar and hyoid movement via the mylohyoid muscle group. And then the cranial nerve connections, or the nuclei connections in the brainstem, these are not all of them, but these are the ones that I think are important to be mindful of in terms of what this could, when we're clinically assessing these patients, what we could, expect. So sensory nuclei, that the trigeminal nerve connects to, the mesencephalic nucleus, the principal sensory nucleus, and the spinal trigeminal nucleus. And remember, those are all throughout the brainstem. And then the motor nucleus, primarily the trigeminal motor nucleus within the pons. The facial nerve, cranial nerve 7, it has a very small sensory function. It contributes to the sensing the anterior 2/3 of the tongue, whereas the posterior is controlled by the glossopharyngeal and vagus nerve branches. So the motor function of the facial nerve, you will obviously, that's the nerve that controls the muscles of the face, and then some hyoid muscles. So we're also plays some role in kind of that hyoidal elevation excursion when we're thinking of patients with dysphagia. The nuclei to be familiar with in terms of what the facial nerve connects to, sensory-wise, those afferent or sensory branches connect to the nucleus of the solitary tract, which is a very important sensory nuclei we'll get into in a second. And then the motor nuclei, obviously the facial motor nuclei within the bilateral pons. The glossopharyngeal nerve, or cranial nerve 9, sensory function, we have taste to the posterior 1/3 of the tongue, sensation to the middle ear, the palate, the facial pillars, the tonsils, the pharynx, and then the sensory limb of the gag reflex. And then motor function controls pharyngeal movement via the stylopharyngeus muscle group. Nuclei within the brainstem that the glossopharyngeal nerve connects to. Sensory, the nucleus of the solitary tract, and then motor, the nucleus ambiguous in the medulla. The vagus nerve, cranial nerve 10, sensory function, taste, contributes to taste in the oropharynx, like the pharyngoepiglottic region. And then sensory function of the pharynx, the larynx, and the trachea. So obviously this is a very important nerve that we need to be very familiar with when working with patients with dysphagia and dysphonia. Motor function, vocal cord movement, so the laryngeal abductors and adductors, velopharyngeal closure, pharyngeal constriction, UES relaxation, and then the motor limb of the gag reflex. Nuclei that the cranial nerve 10 connects to, the nucleus of the solitary tract, the sensory nucleus, and then motor, the nucleus ambiguous in the medulla, and the dorsal motor nucleus in the medulla. And then lastly, we have the hypoglossal nucleus, cranial nerve 12, has no sensory functions, no afferent or sensory branches, is a purely motor nerve that controls all of the lingual muscles except for the palatal-glossus, which is controlled by the vagus. So obviously, this is an important nerve for speech and swallowing, in that if there's damage to the nerve or the hypoglossal nucleus within the medulla, then we can see some pretty prominent oral, lingual, speech, and swallowing impairments. Told you we'd revisit it. So when we think about, I'm going to go back to this, the last column there, when we're thinking about what are the nuclei that really I should be familiar with when I'm, as somebody that's working with patients with neurogenic disorders. So for example, let's take the vagus nerve, connects to the nucleus of the solitary tract in kind of mostly the medulla, and then the nucleus ambiguous and dorsal motor nucleus within the medulla. So if you want to visualize that, those are their, let's see, the motor nuclei, if we look at the right side of the brainstem, remember they're all paired, that the hypoglossal nucleus and the nucleus ambiguous, so those are all of the lower motor neurons that communicate with the hypoglossal nerve and the glossopharyngeal and vagus nerve, are all kind of clumped there together in the medulla. So if you have somebody that has a medullary stroke, you can have some pretty prominent dysphagia, because these motor neurons are now compromised and not able to communicate with the hypoglossal, vagus, and glossopharyngeal nerves. So revisiting the cranial motor pathway. So again, the first kind of part of the sequence, the first order neurons are the upper motor neurons in the motor strip or the precentral gyrus. That is where the electrical signal is generated. Then it's sent along the axons of the upper motor neurons via the cortical bulbar tract, which is within the internal capsule. The axons then pass through the midbrain and become the cerebral peduncles. So now we're at the level of the brainstem and the midbrain. They then synapse at each appropriate cranial nerve nuclei in the brainstem. And then the last part of that sequence is the motor signal or message is then sent to the muscles via the motor efferent cranial nerves. And those are the kind of rootlets that are coming from the nuclei themselves. So getting into the cranial nerve exam as part of hopefully a comprehensive swallow evaluation, speech and swallowing diagnostics, like I mentioned earlier, maintenance. So if we are seeing a patient that had, one day the cranial nerve exam looked like this, and then maybe something like an evolving stroke, and we can see, okay, this could be an evidence of a changing or evolving status, and it's something to be mindful of or to note. So it's not really about, mapping like a deficit to a treatment plan. It's more so about the usefulness of this information and how we use it in terms of, serial assessment of patients, especially like in the acute care setting, and diagnostics. How are we synthesizing this information in order to make inferences about diagnoses, contribute to the differential diagnosis to the medical team? It is really, really one of the most valuable tools that we kind of complete as speech pathologists. So Dr. Berkowitz is an incredible neurologist. He has one of my favorite books. That's so nerdy. He has one of my favorite textbooks that he wrote on like foundations of neurology, and it's really easy to follow. It's really easy to understand. I have it referenced later in the slides. But what he says is the cranial nerve exam evaluates the neurologic functions of the structures of the head and the neck. Although this portion of the exam is called the cranial nerve exam, it also tests the brainstem, which we know now is the site of the cranial nerve nuclei. And in many cases, the cerebral hemispheres, which are the ultimate recipients of incoming sensory information from the cranial nerves. So for example, vision, hearing, taste, smell, facial sensation, and which provide descending or motor control of the motor functions of the cranial nerves to the muscles of the head and the neck. So I think this just paints the picture so well that when we're talking about the cranial nerve exam, like, yes, we're assessing the integrity of the cranial nerves themselves, but we're also assessing the integrity of all of these other structures that communicate with the nerves. So just kind of something to be mindful of. So remember, before we get into the kind of the clinical application, the cranial nerve exam, bilateral innervation means that both the left and the right cerebral hemispheres have descending cortical bulbar fibers that synapse at both the left and the right cranial nerve nuclei in the brainstem. And I have a picture because I know somebody's thinking about it. Unilateral contralateral innervation means that those descending or efferent motor cortical bulbar fibers of the upper motor neurons synapse mostly at the contralateral nucleus. And again, when we're thinking about the facial nucleus, this is sheerly because of the organization of the nucleus, and the hypoglossal nucleus, mainly like the bulk of the motor neurons are the motor neurons of the genioglossus muscles that protrude the tongue. So when you have lower motor neuron damage or actual nerve damage, that part, the genioglossus, will then atrophy or become paretic. And when you stick the tongue out, it'll deviate because the strong side is pushing because there's no opposing force. So again, kind of the organization of the nuclei, but largely because when we're looking at tongue protrusion, that's largely the genioglossus, and that's kind of the bulk of the hypoglossal motor neuron. Okay, again, no artist, but it's so hard to understand this without some type of visual. So we have the right and the left side. For the purpose of this picture, again, I didn't want to make it like so visually distracting, but the cortical bulbar tracts or the axons on the right there, of course, they're also on the right of the picture, on the left side of the brain in this picture. Of course, they're bilateral, but I didn't want to make it too distracting. So for the purpose of this, we'll look at the left cerebral hemisphere. You can see the little like dots. Those are the areas of the motor strip where the upper motor neurons are. So the upper motor neurons of the facial nerve, the upper motor neurons of the trigeminal nerve, all the ones that we talked about previously. And then those descending tracts, if you look closely at the brainstem, so the upper part of the brainstem is the midbrain. Then in the middle, we have the pons, and the lower part is the medulla. So as those tracts descend, so let's like pick one, for example, that has bilateral innervation. If you look at cranial nerve 5. So you see the upper motor neurons there in the motor strip of cranial nerve 5. And then you see the descending tracts that communicate with the pons there in the like superior pons, the very upper part of the pons. They're getting, both of the nuclei are getting input from the cortical bulbar fibers of the left hemisphere. So from that hemisphere, those fibers are communicating with both of the cranial nerve nuclei. And if you think about, if you visualize what this would look like from the right hemisphere as well, you have bilateral innervation going to both of the nuclei. So both nuclei, left and right. Whereas if you look closely at like the hypoglossal nucleus, that nucleus is only getting innervation from the contralateral motor strip. So in this case, I drew out the cortical bulbar tracts of the upper motor neurons of cranial nerve 12. In the left hemisphere, they are descending and crossing over to only innervate or give signal to the right hypoglossal nucleus. And this is why clinically, this is such an important tool that something as simple as looking at if there's lingual deviation can tell us a lot about lesion location. And then I put down there at the bottom where the X is, that's where the corticospinal tracts will then decussate or cross. So they decussate like right where the medulla reaches the cervical spinal cord. And so that's why we see contralateral deficits in terms of like body impairment. So if somebody has a right cortical stroke, we see left arm and leg weakness because those corticospinal tracts that are communicating with the spinal cord are decussating right below the medulla. So getting into the cranial nerve exam, we'll start with the trigeminal nerve, cranial nerve 5. So remember, this is a nerve that contains sensory or afferent branches and motor efferent branches. So first, this is what I do. I'm sure there's people that do similar things or maybe more. But first, I'll have the patient close their eyes and I literally just say, tell me where I'm touching. So you want to assess the ophthalmic area or the branches of the ophthalmic area, the maxillary branches, and the mandibular region, because all of these, the trigeminal nerve sensory branches branch out across the face. So you want to make sure that you're assessing bilaterally, but all of these regions. Intraoral sensation. So are they feeling like if you have a spoon or a straw or a tongue depressor and you tap the palate or the anterior tongue or the lateral sulci, are they feeling that? Of course, subjective, but sometimes I'll have a patient say like if their eyes are closed, I feel it more so on the right and I don't feel it as much on the left. And so then you're thinking, is that consistent with what I know about where their lesion is? Opening their mouth. So when they open their mouth, is there any deviation? So the trigeminal nerve, again, has bilateral innervation. So if you have something like a unilateral cortical stroke or tumor or bleed, you shouldn't see jaw deviation because there's the contralateral hemisphere is a fail-safe. It's also giving innervation. So even if that right hemisphere is damaged, that left hemisphere is giving input to those nuclei in the pons. But of course, it's always possible because if you have a large or a really dense stroke, potentially those structures are getting a lot less input. So you could see some weakness, but it's pretty rare. Jaw opening against manual resistance. So have the patient open their mouth, and then you are pushing up against their chin to see is there reduced resistance. Are they having trouble with that task? Tell the patient to clench as if they're chewing, and then feel the bulk of the temporalis and the masseter muscles. You want to make sure, obviously, that they're symmetric, that you're feeling kind of the same bulk or activation on both sides. And again, cranial nerve 5 does have bilateral innervation. So like I said, a unilateral upper motor neuron lesion, like a right cortical stroke or a left frontal tumor, a left internal capsule lesion, shouldn't cause any huge impairments because the other hemisphere is compensating. Where on the contrary, when you have a unilateral lower motor neuron lesion, like a peripheral nerve tumor compressing the actual trigeminal nerve branches, or let's say like a large pontine stroke that has now compromised those motor neurons in the brainstem, you could see deviation to the ipsilateral side. So for example, if you have a left trigeminal nerve tumor, patient opens their mouth, you'd see jaw deviation to the left and reduce force of mastication on the left or affected side. So obviously something that could imply maybe some disorder in terms of speech and swallowing. So when we do all these tasks, like what are we testing the integrity of? I mean, we know we're testing the integrity of the motor branches, the nerve itself. We're also testing the integrity of the trigeminal motor nucleus in the pons, the cortical bulbar fibers or tracts that are innervating those nuclei, the upper motor neurons and the lateral motor strip. So those are all things that have to be intact in order to see no obvious clinical impairment. Sensory-wise, what are we testing? We're testing, again, the nerve itself, the afferent or sensory branches, the sensory nuclei in the brainstem, and also the thalamus, the integrity of the thalamus, because it is ultimately what helps it relay the information up to the cortex, the sensory tracts within the internal capsule, and the somatosensory cortex in the post-central gyrus, the parietal lobe. So all of those structures have to be intact and working or functioning in order for all of this to be normal. And that's just, again, highlighting when we're doing these cranial nerve exams, we're not just looking at the cranial nerve. That's probably one of the smallest things. We're looking at all of these kind of synapse points of that motor signal. The facial nerve, cranial nerve 7. This is one too that, again, you can see, so you can get so much information clinically just by looking at a patient, seeing if there's asymmetry, facial asymmetry, looking for signs like ptosis or eye drooping, reduced tone or like hypotonia, flattened nasolabial folds, like in the case of a stroke that's affected the cortex or the upper motor neurons, and you see a central facial droop, so only the lower part of the face is affected because of that layout of the facial motor nucleus. You might see like let's say a left central facial droop, and you see that nasolabial fold looks flatter when you're looking at the patient compared to this, because it's not getting the activation that the right side or the intact side is getting. So having the patient smile, looking at the symmetry of it, Pucker your lips against a tongue depressor, perform alternating motions, plosive sounds, so sounds that require them to generate some type of air or intraoral pressure. Maintaining pressure in the cheeks. So I say puff up your cheeks with air and I want you to hold it and don't let me get it out. Like maintain that pressure. Listen and look for air escaping labially. So if somebody has let's say that somebody's had a compromise to the right upper motor neurons or tracts, and they have a central left facial droop with the lower facial muscles, and you have them do this task, sometimes you'll hear air escaping from the left side of the mouth because those lips aren't getting that activation in order to close it and create that resistance. Have the patient lift up their eyebrows. I say, do like you're scared, now like you're mad. Make sure that both sides of the upper face or the forehead are getting that symmetric activation. You can assess the kind of the special sensory taste function by looking at taste and like having the patient taste a variety of flavors. I will say this is, I've never done this in acute care, but I do ask about perceptual changes in taste. Because remember, the facial nerve has sensory function that grabs sensory information related to the anterior 2/3 of the tongue. So again, when we think about the innervation, the bilateral innervation, the forehead, the upper facial muscles are getting that bilateral innervation, while the lower face is only receiving contralateral innervation. And again, this is just the way the brainstem nuclei are arranged or kind of formed. And what does that mean in terms of implications for upper motor neuron and lower motor neuron damage? So if you have a patient that has, let's say you're doing a cranial nerve exam, you have them do all these tests that are listed here above, and you see the whole right side of the face is not moving, but the left side is getting movement. And so you see like just ptosis, flattening of the nasolabial fold, air escape when they're doing intraoral pressure tasks. Well, that would be concerning for lower motor neuron and or facial peripheral nerve damage. And that is telling in terms of if the medical team is trying to locate, lesion. So a unilateral lower motor neuron or peripheral nerve lesion, like we just talked about, something like Bell's palsy, which is essentially like a reaction that leads to like facial nerve inflammation, so that facial nerve is not able to activate those facial muscles. A facial nerve tumor, so like compression of the facial nerve. These will cause ipsilateral or same side impairments of both the upper and the lower quadrants. So think about that pathway, that kind of that sequence of events that we've talked about. Everything up above is okay. We're getting the upper motor neurons are working, the cortical bulbar tracts are communicating with the facial motor nucleus. And then once we hit that lower part of the sequence, or the end part of the sequence, if there is some type of compromise to those structures, then that's when we see ipsilateral deficits, because that nerve is not able to communicate with that muscle. And important to note that it does have a small role in hyoid movement via the stylohyoid and the posterior belly of the digastric muscles. So some implication for swallowing impairments. So the glossopharyngeal and the vagus nerve, cranial nerves 9 and 10, really important nerves branches, because when we think about the muscles of the larynx and pharynx, these are the two nerve groups that are innervating these muscles. So palate movement, have the patient say ah, like a maximum phonation time, looking at their palate movement. Is it symmetric? Are they getting good elevation bilaterally? Does one side look like it's drooping? And I will say this is kind of a tricky one in that a lot of people just have some normal variation in their palate. Some people have just asymmetry in their palate. And in the absence of any other clinical manifestations or clinical concerns for vagus nerve or glossopharyngeal nerve deficits, I wouldn't think much of it. Whereas if somebody has an asymmetric palate, they're hypernasal, they've got signs of pharyngeal dysphagia, dysphonia, like that is something where I would say, yeah, that's probably a true asymmetry. And this is the pharyngeal branch of the vagus nerve that innervates the palate. So that pharyngeal branch bilaterally is why it's able to elevate. Vocal quality during conversation, just listen. So subjectively, does the vocal quality sound rough? Is it breathy? Does it sound strained? Like they're trying to like there's a tension, or they're trying to strain to get the voice out? Are there phonation breaks or like blocks where there's no voice coming out at all? Volume, is the volume low? So all of these kind of qualities that we're assessing clinically have to rely on intact vagus nerves bilaterally. Pitch range, have the patient glide on E, and I literally say, I'm gonna see how well the muscles of your vocal cords are working, because that can tell us more about swallow function. So I want you to, and I'll model it. I want you to glide on a low E to a high and a high to a low. I'll model it again. See if they're getting good pitch variation. And when we're doing this, we're really assessing the integrity of the superior laryngeal nerve branch of the vagus nerve, because that is the nerve branch that controls the cricothyroid muscles, which elongate the vocal cords. So perceptually, what's leading to pitch change. Maximum phonation time, having the patient say ah on the deepest inhalation or inspiration and time it. I say 2-3 times is ideal, because almost always, especially when you have patients that might have like a co-occurring like delirium or encephalopathy or cognitive impairment, that this might be confusing. So I always give a model and I have them do it a few times and see like, oh, was that you can do better than that. Was that your biggest breath? Was that your deepest breath? And seeing how long that maximum phonation time. There is like norms and research for this, and you can look those up like in the voice literature, but in like the critically ill or acute care population, we're wanting this to be like 14 and above seconds. And when we're doing that, we're looking at the integrity of the recurrent laryngeal nerve, which is in control of the laryngeal adductors. So the muscles that close off the glottis and adduct the vocal cords. S to Z ratio. And again, this is kind of like maximum phonation time. I'll have them do it 2-3 times. And it's looking at the kind of the coordination of the respiratory and like phonatory function. If somebody has some type of laryngeal pathology or vocal cord structural lesion, or tumor in the glottis, nodule, cyst, this might be abnormal. So you essentially have the patient say s as long as they can and z as long as they can. So you've got a voiceless and a voiced of the same sound, and you're seeing how well, again, the phonatory and respiratory systems are coordinating. Throat clear and cough. Okay, yeah, pretty perceptual or pretty subjective, but are they perceptually strong? Are they perceptually weak? Does this patient have an obvious dystocia or impaired cough? I saw a patient yesterday who had a lot of pulmonary comorbidities, lung cancer, metastasis, and they were saying, my cough is so weak now. So you can gain a lot just from what the patient's saying, but also having them do a volitional cough. Now, the caveat to this is when we're thinking about cough function, one of the most important things in the back of our mind is if the patient were to aspirate, would that cough reflex be intact, but would it be strong enough in order to eject that aspirate? And volitional cough is much different than a reflexive cough. But it's still something to note. If somebody has an obvious, true, weak cough, they're going to be at a higher risk for maybe some pulmonary complications from an aspiration event. So objective measures, you can do like a peak flow meter, collaborate with respiratory therapy to see if they have some more like less subjective, more objective tools to kind of get that true data, those true numbers. Sometimes limited just based on what your setting might have. Briefly touched on this, but the branches of the vagus nerve, so there's several branches. When we're thinking about speech, voice, swallowing, these are the branches that are important to kind of be familiar with. That pharyngeal branch aids in pharyngeal constriction and shortening. So we're thinking about the pharyngeal squeeze and that like stripping wave, palate elevation. Superior laryngeal nerve, like I said, has the elongates the vocal cords so that we can subjectively hear change in pitch, and it has sensory or afferent branches that allow for sensation to the mucosa above the level of the vocal cords. So like that whole supraglottic space right above the glottis. So for example, if somebody penetrates on a swallow study, what would we expect if the superior laryngeal nerves are intact bilaterally? We'd expect either a secondary swallow or a throat clear in response to that penetration. Recurrent laryngeal nerve, vocal fold or vocal cord adduction and abduction, so the ability to move the vocal cords, and has sensory or afferent branches that send sensory information about sensation to the mucosa below the level of the vocal cords. So this is where we're thinking, okay, if somebody has, let's say, some type of compromise to this nerve, whether it's at the level of medulla and the nucleus ambiguus, not getting that the sensory nuclei or the nucleus of the solitary tract are not intact, that if they're not able to receive that sensory information, will that person, let's say if they aspirate on a swallow study and material falls below the level of the vocal cords, is there a cough response to that aspiration? So when we're thinking about that, that's controlled by the recurrent laryngeal nerve. Glossopharyngeal and vagus nerves, cranial nerves 9 and 10 do have bilateral innervation. So in the case of an upper motor neuron or unilateral cortical lesion, like a unilateral cortical stroke, we shouldn't see any huge issues. And I say that because we can certainly see an acute dysphagia in a patient that's had like a right MCA stroke, because all those structures below within the brainstem and the nerves themselves are getting less input. Whereas with the lower motor neuron or peripheral nerve lesion itself, like a lesion that's affecting the actual nerve itself or the nucleus ambiguus, the lower motor neurons in the medulla, we will see more prominent impairments because that is the last pathway, the last part of that pathway, so that the muscle can get that message. Hypoglossal nucleus, we talked a little bit about assessing lingual protrusion. Is there deviation? If there's upper motor neuron damage, it will deviate to the affected or the contralateral side. So in the case of a left MCA stroke, for example, we might see a right lingual deviation because there's no opposing force. That right hypoglossal nerve is not giving that activation to that right genioglossus. So we're seeing when the patient sticks their tongue out, the strong side will be pushing because there's no opposing force. Same thing with lower motor neuron or direct nerve damage, it'll deviate to the affected side. And in the case of a lower motor neuron or hypoglossal nerve injury, it'll be the same side as the compromise. Looking at lingual range of motion, having the patient lateralize the tongue vertically, looking at it subjectively, kind of looking at strength, having the patient, I will either have a tongue depressor. I typically do my gloved finger and have them press their tongue tip on both sides against my finger within their cheek. And again, it's limited because it's more subjective. But if somebody has a prominent lingual weakness, you can gain some information from doing this. And I always mention too, just considering things that could impact this. Apraxia, so if somebody has like a motor planning issue, like groping, or clearly are not getting that like motor sequence is off, you might see some difficulty doing this, not because there's a weakness, but possibly because there's an apraxia, which is a more of a motor planning issue. Cognitive considerations, of course, when you're working with patients, especially in acute care and patient rehab that have cognitive impairment to some degree, whether that's an acute, temporary, transient thing like encephalopathy or something like dementia, where that might be impacting their ability to do this too. And that's always something important to note. You know, if somebody has an not a true weakness, but just some type of impairment that's affecting how you can do this exam, you don't want to label it as a weakness. Hypoglossal nerve has contralateral innervation, so the descending or efferent fibers synapse mostly at the contralateral hypoglossal nucleus for the genioglossus muscles, which we talked about before. If there's an upper motor neuron lesion, it'll again deviate to the impaired side, the contralateral side. And if there's a unilateral or lower motor neuron lesion, it'll deviate to the ipsilateral or impaired affected side. You might also see like lower motor neuron signs that we talked about earlier. If somebody has, let's say that somebody had a procedure and a surgeon had to remove a tumor and they had to sacrifice the hypoglossal nerve, let's say they cut it. If that right hypoglossal nerve was compromised or cut during a procedure, you might see tongue deviation to the right because that side is atrophied. It's not getting any activation. You might also see like really like atrophy of the tongue. You might see fasciculations on the affected side, just flaccidity. So remember those lower motor neuron signs. And now we're going to get into the more of the case applications. So we will start with case application of the cranial nerve exams, and then we'll go into case application of more like comprehensive case studies. I hope y'all are still bearing with me. Okay, so let's start out with left cortical stroke. So let's say that you're evaluating a patient who comes to the hospital, you're checking out their imaging, what their brain imaging says, and they had an MRI brain, which was notable for a region of hyperintensity and diffuse restriction in the left supramarginal gyrus of the parietal lobe. So right off the bat, based on everything that we've kind of talked about so far, if there's damage to the parietal lobe, will I be expecting prominent motor issues? No, because the motor strip is anterior. It's controlled anteriorly. We see it in the precentral gyrus. So if somebody has compromise to kind of the posterior structures of the brain, I wouldn't expect prominent weakness unless there's also involvement of those subcortical tracts, like the internal capsule. So let's say we do the cranial nerve exam, and this is what I'm writing up in the actual diagnostic report. Cranial nerve 5, sensation intact, the various branches of the facial or of the trigeminal nerve that control facial sensation intact bilaterally, mandibular strength and range of motion intact bilaterally. We're not feeling any asymmetry between the bulk of the masseter and temporalis muscles. Cranial nerve 7, labial and buccal strength and range of motion grossly intact bilaterally, no obvious orofacial asymmetry. Both the upper and lower facial quadrants are symmetric both at rest and when activated, when they're actually moving the facial muscles. And the patient denied any perceptual changes in taste. Cranial nerves 9 and 10, palate is symmetric at rest and with movement or with activation. So when you're having the patient say ah and you're looking at the palate, it's moving symmetrically on the right and the left side. Maximum phonation time 22 seconds, which is good with the normal limits. Perceptually strong cough, clear vocal quality, good volume, pitch variation intact. So really we're not seeing anything so far. Cranial nerve 12, the hypoglossal nerve, we don't see any lingual deviation. The lingual strength and range of motion are perceptually intact bilaterally. So overall, this is an insignificant cranial nerve exam. There's nothing that's sticking out that's telling us there could be some acute compromise to some type of bulbar muscle or sensory tract. So again, with a case of a cortical stroke that is more posterior, if it's preserving all of those tracts, the sensory and motor tracts, the upper motor neurons, we shouldn't see any prominent changes like a facial droop or lingual deviation. So this is a normal cranial nerve exam. Somebody that's had a carotid endarterectomy, that is a procedure that essentially the surgeon will make an incision in the neck and they go into the artery and basically clean it out in order to avoid things like stroke. So this patient their incision site was the right lateral neck. And to run through this so we have time for the case studies, cranial nerve 5, normal, not seeing anything significant. Cranial nerve 7, not seeing anything significant, good facial activation, it's all symmetric, no facial drooping. When we get to the tests that are assessing cranial nerves 9 and 10, we see the palate movement is symmetric. So we're thinking, okay, the pharyngeal branch of the vagus nerve is working. Maximum phonation time is 6 seconds, which is pretty low. Perceptually reduced cough strength, so maybe some dystocia, significantly breathy voice or vocal quality, and low volume, and you also appreciate phonation breaks. So that is obviously abnormal. And then we look at the cranial nerve 12, we're not seeing any lingual deviation, lingual strength and range of motion are good. So what might I be communicating to the medical team is this cranial nerve exam is atypical, and I have a suspicion for possible iatrogenic or the result of some medical management. Peripheral nerve damage of the right recurrent laryngeal nerve. Refer for imaging with ENT. So this might be the case where like they do like laryngeal electromyography, or they're getting an MRI of the neck. They're looking at, they're consulting ENT to do direct laryngoscopy. Let's say I do a FEES on this patient. If the right recurrent laryngeal nerve is in fact damaged or compromised from this procedure, I might see a right vocal cord paresis or paralysis. So that's something to kind of think about when the actual nerve itself is damaged. We have those ipsilateral impairments. And I also wanted to mention this, I have seen a patient before who had a similar procedure. It was not this, but it was a similar procedure. And following that, they had like a profound pharyngeal dysphagia. And we were all putting our minds together and we were like, what is going on? And I think what the medical team kind of came to the conclusion about was that they think there was like a neuropraxia, where it's like, the nerve was like kind of like irritated or aggravated, but it wasn't totally cut. It was just maybe stretched or bent. And so that the nerve is not giving the input to the muscles, and it kind of gains that function back over the next few months. And that's actually what happened with this patient. So very interesting, neuropraxia. Stroke versus Bell's palsy. So let's say a patient was admitted with acute facial drooping, and the medical team is trying to rule in or out stroke versus, is this a Bell's palsy, which is essentially a reaction at the level of the facial nerve. So they do, as part of their diagnostics and workup, they do a CT head, which is negative. MRI brain is pending. The patient was started on steroids and antivirals. So typically, Bell's palsy is like a reaction to possibly like a viral infection. And like I said, it kind of causes some inflammatory changes in the facial nerve. So that's why they might start them on steroids and antivirals. Cranial nerve exam, everything is normal except for the task that when you're assessing cranial nerve 7, you see a hemifacial paresis paralysis on the right. So both the upper and lower facial quadrants have limited to no movement during activation. So when you tell the patient, when you're having the patient do all those tasks that we talked about, are you seeing symmetry? You're seeing the right side is not moving, but the left side is. So you see poor eye closure, ptosis, drooping, very limited labial movement, almost no forehead movement. So all of that is indicative of either lower motor neuron and or peripheral nerve damage. Palate symmetric, no lingual deviation. So we're seeing a cranial nerve that is significant, basically isolated to the facial nerve itself. And in this case, this patient did indeed have Bell's palsy, and their MRI brain was negative. So case application, more comprehensive patient scenarios. And before we get into, dysphagia assessment and all of that, it's important to know, like, what do we expect just with general aging? The biomechanics of the swallowing change as we age, just like the biomechanics of lower and upper extremity movement changes. You have a lot of things that happen. You have reduced elasticity of the lungs, so we can see a decrease in pulmonary reserve. So when we're thinking about the subglottic pressure, that's really important in order to tightly close off the airway and the vocal cords. Is it reduced? Are we getting less closure or less airway protection at the level of the upper airway? There's some degree of neuronal cell death. So as the nervous system ages, the neurons die. I mean, this process, like I said earlier, apoptosis, it happens. The neurons die, and that is expected as the body ages. In addition to that, we have the speed and the velocity of nerve conduction or action potentials, those electrical signals along the axons decreases. So whether it's like reduced number of like myelin, the sheath that covers the axons, or there's just reduced bulk of myelin, we see that those axons slow down. And so what are the implications of action potentials that are slowing down? Well, we're going to see less activation of the muscles via the nerves. The UES duration and the duration of the laryngeal vestibule closure increase. So perhaps maybe some protective factors against airway invasion events that could improve airway protection as that whole mechanism ages. And then lastly, penetration within liquids is normal. So, I mean, even intermittent penetration aspiration can be normal. So it's not always atypical or a disorder when we see some degree of airway invasion on modified barium swallow studies or fees. Now, this obviously, there's so many other factors that go into it, but this is where something like the digest, which I'll talk about in a second when we get into case studies, really can be helpful in terms of how frequent are these events. Does it happen one time and then the rest of the trials are normal? Well, then it's pretty insignificant to me. And that's why this tool that I'll talk about in a second is really helpful. So let's say case one, we'll go through the history and physical, the H&P first. Patient was admitted after reportedly choking on a hot dog and concern for esophageal impaction. They are now status post EGD with bolus removal and esophageal dilation due to a noted mild esophageal stricture. Patient does have a history of neurodegenerative disorder. Type is unspecified. According to the patient and the family, she has seen multiple neurologists and providers due to a decline in motor function over the past year. They have not received any definitive diagnosis. Per patient's husband, an MRI brain was negative at an outside facility, and initial EMG study done several years ago may have been abnormal, and all the outside records are not available. So we're relying on kind of the interview with the patient and the family. Initially, symptoms were isolated to leg weakness, and then they progressed to upper extremity weakness, and more recently in the past few months, bulbar weakness, so muscles of the head and the neck, that has caused severe dysarthria with need for alternative means of communication. So for example, writing. Patients dependent on gestures and writing in order to communicate. The patient and family report she has seen an SLP for a clinical swallow evaluation or screen in the past, and there were no concerns for dysphagia in the past, but that was several months ago, and obviously the disease has progressed. And since last seen by SLP, speech and swallow function have significantly declined, and the patient's now admitted with a presumed dysphagia-related complication. At the time of the session, the patient's upright in bed, breathing comfortably on room air, alert and oriented, grossly cognitively intact, but like we mentioned, severely dysarthric and communicating mainly via writing and gestures. So other objective information that we're going to look at, labs, because the labs can tell us a lot about what a patient's body is actively going through. White blood cell, normal. Procalcitonin, normal. So that's a protein that's basically released into your bloodstream when you're fighting off some type of acute infection, typically a bacterial infection. So that's not elevated, so it's normal. Neutrophil, a specific type of white blood cell, normal. Oxygen, respiratory rate, temperature, all normal. So clearly this patient's not fighting an active or acute infection. CT soft tissue neck, essentially everything is unremarkable, nothing structurally abnormal. Glands normal, intracranial structures that are visualized on this exam normal. Included lung apices, visualized lungs are clear. There are tracheobronchial secretions. No obvious foreign body, patulous fluid-filled esophagus. Debris partially visualized in the mid-thorax, consider an EGD. CT of the chest, central airways are patent, trace scattered debris, so that's something that we already know. No focal consolidation, pneumothorax or pleural effusion, and a low density material within the mid to distal esophagus measuring up to 4.5 centimeters with a mild upstream esophageal dilation, concerning for impacted food bolus. So let's say I go into do my clinical swallow evaluation and communication assessment. This is my actual write-up for what I am putting in the diagnostic report. Patient seen this date for clinical swallow evaluation in the setting of unspecified neurodegenerative disease. Admitted with esophageal impaction, now status post EGD with bolus removal and dilation. Per patient family, lower extremity weakness began about 2 years ago and has since ascended and worsened and now involves the upper extremities and the bulbar muscles. They deny any history of pneumonia or weight loss, but do report progressive dysphagia symptoms such as drooling, coughing, choking, and globus sensation or need for multiple swallows. The patient also states that she feels meals take her much longer now. Today, the cranial nerve exam is atypical, significant for reduced facial tone bilaterally, poor labial movement seal, poor intraoral pressure, reduced palate movement bilaterally, in addition to hypernasality, reduced lingual range of motion, perceptually reduced lingual strength bilaterally, and lingual fasciculations. So these deficits are concerning for upper and or lower motor neuron involvement of cranial nerves 7, 9, 10, and 12. With a single sip of water, noted anterior loss due to reduced labial seal, as well as immediate throat clearing, coughing, and need for multiple swallows. Patient is presenting with oral dysphagia and suspected pharyngeal dysphagia. Recommend modified barium swallow study in order to objectively assess swallow function, pharyngeal airway protection, screen esophageal function, and guide the treatment plan. So what is the safest oral diet that we might recommend? What are some compensatory strategies or maneuvers that we might recommend? Due to the patient's acutely increased risks for aspiration pneumonia, such as acutely limited mobility, known history of reflux, recommend that this patient remain NPO except for limited ice chips or sips of water after oral care, pending the modified barium swallow study, which is tentatively planned for within the next few hours. So that's the clinical swallow evaluation. And then the motor speech and communication evaluation, patient is presenting with severe dysarthria, most consistent with a mixed spastic flaccid type, characterized by a significantly impaired articulatory precision, slowed articulatory motions, and hypernasality, leading to consonant and vowel distortions and impaired ability to create appropriate pressure generation, so plosive sounds for speech. Patient largely communicates via writing due to severity of rapidly progressing dysarthria. Provided the patient with a communication board to aid in alternative communication. And in this case, this is a patient who we also trialed some more high-tech AAC with. Due to abnormal cranial nerve exam, dysphagia with rapidly declining progression pattern, mixed flaccid dysarthria. Presentation is concerning for possible motor neuron disease. Recommend a neurology consult for further assessment of potential central nervous system involvement. This was verbally discussed with the hospitalist. SLP will continue to follow for speech, language, and swallow treatment. So let's say then we do the modified barium swallow study, and these are the results or the write-up of the MBS report. Patient is presenting with severe oral dysphagia, characterized primarily by significant anterior bolus loss, disorganized lingual movement, slow, effortful anterior to posterior lingual propulsion, piecemealing, prolonged reduced mastication, and premature spillage of liquids due to reduced oral control. And moderate pharyngeal dysphagia, digest score, safety 1, efficiency 2, primarily characterized by poor base of tongue retraction, reduced pharyngeal contraction and shortening. These physiologic deficits lead to consistent, non-clearing penetration of thin liquids into the supraglottic space and to the vocal cords. So penetration aspiration scale scores of 3 and 5 respectively. On about half of the trials, patient was able to spontaneously eject the penetrant from the vocal cords to the supraglottic space, but was unable to fully eject it from the upper airway. Also noted moderate pharyngeal residue, up to 45 to 80% of the bolus in the vallecular space and along the area epiglottic folds and in the bilateral piriform. So we're seeing some kind of globally reduced pharyngeal weakness, with patient requiring multiple swallows to improve pharyngeal clearance and presumed intact sensation because they were doing this spontaneously. They were feeling the residue. When patient completed a volitional effortful swallow, noted slightly improved prandial airway protection and pharyngeal clearance. Overall, swallow safety, airway protection is mildly impaired, and swallow efficiency, pharyngeal clearance is moderately impaired. Following this study, extensively reviewed the results with the patient and the patient's husband, including option for continuation of thin liquids with softer solids or initiation of mildly thick liquids with softened solids. Reviewed that as a patient's mobile. So now we're going through the patient's individual protective factors. Mobile, cognitively intact, able to complete strict, frequent oral care. They're immunocompetent. They don't have any known autoimmune risk factors or diseases, and they have not acquired any obvious respiratory complications thus far. The risk for aspiration pneumonia is relatively low at this point. So reviewed that, now we go through the kind of the pros and cons of potential dysphagia management options. Review that mildly thick liquids could improve airway protection, but also pose the risk for dehydration, as well as reduced swallow-related quality of life, possibly reduced medication absorption. Patient stated that she does not want to drink mildly thick liquids at this time, and she would like to continue drinking thin liquids despite increased risk for aspiration with thin liquids. Patient and the husband were agreeable to swallow precautions such as single sips, a hard or effortful swallow, double swallow, and risk management strategies like an aggressive oral care regimen, mobility tasks as often as able, upright positioning as often as tolerated, and modifying the way that she took her medications. Recommended close monitoring of the patient's respiratory function by the medical team, a dietitian consult to optimize nutrition, and collaboration with neurology for further guidance on possible dysphagia, dysarthria, etiology, or central nervous system pathology. Patient may also benefit from a respiratory therapy consult prior to discharge from this setting in order to maximize pulmonary clearance or function. So this is a case where, we mentioned at the very beginning, our role is to guide the patient and the family in their decision-making by giving them all of the information, showing them clips from the modified barium swallow study, telling them these are your acutely increased risk factors for potential complications if you do aspirate. But these are also your protective factors in that you're mobile, you have not acquired an obvious, bronchopulmonary infection so far. So now that you're in the hospital and you're not moving around as much, and there's some increased risk, but you also have these other protective factors. And it ultimately comes down to what the patient and family want, right? And going back to this one, I think when you think about like all the potential etiologies of esophageal impaction, it was probably due to a combination of things, right? I mean, possibly a slight stricture, esophageal stricture, reduced mastication effectiveness, so that patient was swallowing larger boluses, so boluses that were not thoroughly masticated, which can increase the risk for impacting or obstructing the esophagus. And then probably some degree of dysmotility from a like nervous system impairment standpoint. The central nervous system controls the upper esophageal muscles, whereas the peripheral nervous system controls the lower esophageal muscles. But potentially, if there's some maybe central nervous system involvement in this patient, maybe that was also at play. So it could have been multifactorial. Case 2, when presentation doesn't match diagnosis, and what is our role? So this is the assessment section that would be written up in the treatment note. Patient seen today for diagnostic dysphagia treatment and speech language assessment due to reported decline in motor function by the nurse in the setting of a known small acute left subcortical / internal capsule stroke per MRI on admission. So what we know now, subcortical, internal capsule, so those left cortical bulbar tracts could be impaired. Neurology note indicating increased right-sided weakness and an NIH scale score of 8 compared to the NIH scale score of 4 on admission. So if you're not familiar with the NIH stroke scale, essentially a lower, I think it goes from 0 to 42. And you want a lower score. The higher the score, the more obvious or prominent the deficits. So now we see that per the neurology follow-up, their NIH scale is increasing, which you never want to see. At the time of the session, the patient's upright in bed, breathing comfortably on room air, families at bedside. Patient is only oriented to self in place with very limited initiation, typically 1 to 2 word utterances, difficulty following directions, and reduced intelligibility. So you're not only seeing linguistic deficits, but also some motor speech impairment. Patient's family reports decline in speech, language, and motor function since yesterday, including oral pocketing of food more so on the right, anterior spillage of food, slurred speech, and severe right upper extremity weakness. Repeat cranial nerve exam, because we should be doing these cranial nerve exams at every single serial assessment when we see patients, because especially in the acute setting, when there could be potential for acute changes or high risk for something like an evolving stroke in this case, what the information that we gather that we're kind of honed in on or looking at closely could change or impact the medical management. So the repeat cranial nerve exam revealed reduced movement on the entire right side of the face at rest and with activation, i.e. a hemifacial droop, which is concerning for lower motor neuron and or direct peripheral nerve involvement of cranial nerve 7. And this is not consistent with a known left internal capsule stroke, because from a left internal capsule stroke, if we have a compromise to the left upper motor neuron tracts, then we could potentially see a right lower central facial droop, but we would not expect to see a whole hemifacial droop. Patient was unable to complete tasks assessing sensation due to linguistic deficits, with limited PO trials noted oral pocketing, anterior spillage, and signs and symptoms of airway invasion, such as throat clearing and coughing, concerning for oral pharyngeal dysphagia. This entire presentation is a decline from prior assessment by this writer on the initial evaluation. Based on this presentation, concern for possible stroke evolution and decline in swallow safety, prandial airway protection, recommend modification to NPO, except limited ice chips and critical meds crushed in puree after oral care, repeat head imaging to ensure a stable neurostatus, and a repeat modified barium swallow study in order to reassess swallow function and airway protection, and of course, guide the treatment plan. Patient's family verbally taught back all results and recs and were notified by this writer, initiating a code stroke with immediate notification of change in status to the RN and the MD. RN and MD visualized at bedside when this writer left patient's room. So this is everything that I'm putting into the actual documentation itself. So let's say that the hospitalist or the neurologist order repeat. So typically they'll first order a CT head to make sure there's nothing like a bleed, because that would require possibly some emergent surgical intervention. So let's say the CT head's clear, but because of the kind of evolution in physical symptoms, they order another MRI brain, and this revealed new or acute infarcts in the bilateral pons. So why, with what we know now about, if we visualize kind of the brainstem and the motor nuclei, why are we seeing what we're seeing? So direct damage to the lower motor neurons or the actual cranial nerve 7 facial nerve rootlets that emerge from the lower motor neurons in the right pons will cause that hemifacial droop on the right, and damage to the descending cortical spinal tracts within the cerebral peduncles within the brainstem that then continue to descend through the left pons that have not yet decussated. They will decussate lower at the cervical medulla junction, will cause an increased right-sided weakness. So this is a case where, even if the neurologist is noting some change, you can always expect some degree of change or evolution, or something like a completing stroke. Over a course of a few days, you might not see the extent of what a stroke might manifest as. But if you see, a whole change, like a hemifacial droop and a cranial nerve exam, severe, change in motor speech, change in cortically controlled functions like language, those are all pretty big indications that there's probably some type of decline. So in this case, the repeat head imaging was indicated, and potentially change the medical management. I don't recall what exactly happened, but potentially some, increase like anticoagulants or something pharmacological that the medical team decided to do. Okay, case 3, last one. I'm gonna get water for vocal hygiene. So again, when the presentation doesn't match the diagnosis and our role as speech pathologists. A patient comes to the hospital with vision changes, nausea, vomiting. Prior medical history includes diabetes, hyperlipidemia, sinus surgery. The ED provider's note indicates the following are in the differential. So when you look at emergency providers' notes, when all the diagnostics are pending, they'll typically put what they believe are in the differential diagnosis. It could potentially be this versus this versus this. So all the following are in that differential diagnosis: dehydration, stroke, pretty big differences there, vertigo, and diabetic ketoacidosis, which is essentially a complication of diabetes where acids like build up in the blood, and that can cause significant organ damage. So all of those things could potentially present as the following, what we talked about above. CT head is immediately done. It's negative for any acute intracranial pathology. The CTA, the CT angiogram of the actual arteries themselves of the head and the neck indicates moderate stenosis of the bilateral vertebral arteries. So both of the vertebral arteries are stenosed. So is there a risk factor for stroke? Certainly. But no large vessel occlusion. So at this point, if there's no large vessel occlusion, there's no indication for like a thrombectomy or emergent medical management from like a procedure standpoint. Chest x-ray is negative for any acute disease process. So what am I thinking so far? Like just reading this small H&P, this small blurb, what am I potentially thinking in the back of my mind or hypothesizing? I'm wondering, is there an NIH score, an NIH stroke scale score? Is there something like a Glasgow Coma score, a GCS, like so that I can gain more information about their cognitive function? Are there gait changes? Or is there any mention of dysmetria or ataxia or anything that could also be co-occurring with a posterior circulation stroke? Speech or swallow changes? Is neuro consulted? Did they give this patient TPA or TNK, the clot busting drug, if they thought there was a acute ischemic stroke? So these are all things that are running through my mind as I'm completing the chart review. So next I see neurology is consulted. The neurology note indicates dysmetria of both the right upper extremity and left upper extremity. So that overshooting and undershooting pattern that we tend to see with cerebellar involvement. Slightly impaired gait, concern for diplopia or double vision that appears to be improving per the patient. NIH score is 2, so that's pretty low. We want it to be 0 for completely no evidence of anything clinically concerning. Due to the low NIH score and last time, well, unknown, like they didn't know when this symptoms really onset. TNK or TPA is not given. The neurologist recommends an MRI brain, an echocardiogram with bubble study, and permissive hypertension and aspirin or anticoagulant therapy. So right off the bat, the neurologist is thinking, well, let's treat this as if there's an acute stroke, ischemic stroke, by allowing some degree of permissive hypertension, meaning if blood pressure is a little high, that's okay, because that'll perfuse those areas of the brain that potentially are damaged. Aspirin or anticoagulant therapy, blood thinners, and echocardiogram with bubble is essentially a ultrasound that uses like saline bubbles to detect possible like folds or holes in the heart. So if there's something like a PFO or a structural issue that could cause stroke. Let's say the MRI brain reveals small areas of ischemia/infarcts in the bilateral cerebellum. You see the patient for a clinical swallow evaluation the following day. And during your assessment, you note dysarthria, poor speech intelligibility, compounded by hypernasality and reduced respiratory support. You also appreciate a unilateral palate droop on the left, reduced maximum phonation time of 9 seconds, and signs of pharyngeal dysphagia, such as coughing when the patient consumed water. Patient reports water is either stuck in my throat or I cough it back up. You message the hospitalist and neurologist stating that this presentation is concerning for evolving stroke. Your message says, "Hi team, I just saw Mr. Johnson in 3:30. This is a completely made up patient. Assessment revealed hypernasality, nasal emissions, palatal droop, dysphonia, possible subtle left lingual deviation, and signs of potential pharyngeal dysphagia or aspiration. These findings are not consistent with small cerebellar infarcts. He's also endorsing worse right upper extremity weakness compared to yesterday. I'm afraid of potentially an evolving stroke. Planning on doing modified barium swallow study today, and we'll let you know how that goes, but he might benefit from some updated head imaging." So repeat MRI brain with and without contrast revealed new areas of ischemia in the left lateral medulla, concerning for a possible pica or posterior inferior cerebellar artery involvement. So I included a picture of the circle of Willis over here, which is essentially like the arterial perfusion of the brain. And if you recall, this patient on their initial CTA did have some stenosis of both of the bilateral vertebral arteries. So if you look down there at the bottom, the vertebral arteries are kind of the base to the posterior inferior cerebellar artery. They branch off of the vertebral arteries. So it makes sense that if we knew those were stenosed, pretty pretty moderately stenosis, that there's a higher risk for some blockage or stroke from that standpoint, from those arteries. So if the posterior inferior cerebellar artery is what supplies the lateral medulla, then that makes sense in terms of why we're seeing potentially some signs of dysphagia. So let's say we do the modified barium swallow study. It reveals mild oral dysphagia and severe profound pharyngeal dysphagia, a digest score of safety 3 and efficiency grade 4. So clearly a globally impaired swallow function, primarily characterized by poor pharyngeal stripping and shortening, impaired duration and distension of PES opening, leading to severe pharyngeal residue that spills or migrates into the laryngeal vestibule, causing aspiration after the swallow, or a penetration aspiration scale score of 7. Recommendations are NPO, accept limited ice chips and sips of water after oral care, largely for oral health, so that we're not, the oral cavity isn't getting extremely dry and resulting in a growth of bacteria, plus swallow stimulation. So we know that if small sips of water or small amounts of water are aspirated, but patient's overall health and oral health is good, there's low risk with that. Intensive dysphagia therapy targeting the physiologic deficits that we identified on this modified barium swallow study. You explain the nature and severity of dysphagia, and that alternative feeding route via a PEG will likely be indicated due to the nature and location of the lesion. So you explain the prognosis and how you expect some improvement in swallow function, just with kind of some spontaneous recovery and intensive dysphagia therapy. But in the interim, in order to kind of maximize not only safety, but also nutrition, they're likely going to need some type of alternative nutrition like a PEG tube. So why were we seeing the clinical presentation that we were seeing on our cranial nerve exam and on our assessment tests? So the unilateral palate droop on the left, because the left lower motor neurons in the nucleus ambiguus, which are in the lateral medulla, are compromised, because if the pica artery is not perfusing to that area and those left lower motor neurons are not functioning the way they should, then they are not sending that message out via the vagus nerve branches to the muscles, and then we see weakness. Subtle left lingual deviation, probably due to some degree of hypoglossal nucleus compromise, which is more so like in the medial medulla. So maybe some ischemia that has impacted some of the lower motor neurons of the hypoglossal nucleus. And then right upper extremity weakness because of the left medullary ischemia. So the medulla has those descending cortical spinal tracts, and then once it reaches kind of the cervical spinal cord at the bottom of the medulla, they then decussate. So you're going to see right extremity weakness because there's left medullary involvement and those not yet decussated tracts. Whew, so key takeaways. Man, I'm good. 8:59. So key takeaways, obviously SLPs are a vital part of the medical team and can play a pivotal role in differential diagnosis and patient outcomes. Cranial nerve exams are crucial, and they should be completed with every serial assessment. Each time we are seeing a patient, especially in the acute care setting, we should be looking, whether it's formally or just quickly and informally, at doing some type of brief cranial nerve assessment. And understanding the nature and etiology of dysphagia will change your treatment plan. So for example, if we have a patient that has an acute cortical stroke, and the prognosis for swallow and recovery is excellent, we might be doing some intensive like behavioral intervention or swallowing exercise based intervention. Whereas somebody that has an acute myasthenia gravis flare, which is a disorder at the level of the neuromuscular junction, and they just need medical management, so something like IVIG or Plex treatment, potentially that could be medically managed, and then we'll see improvement in the swallow function and exercise-based treatment is contraindicated. So, like I mentioned in the very beginning, understanding the whole neurologic process and the implications of that, how that could affect, prognostic information is really important when we're working with patients, especially with neurogenic dysphagia. Whew. Okay. Questions?
Anna, that was amazing. As always, thank you so much for your expertise. We have several questions. I'm going to jump over the chat real quick and see if anyone's
Okay.
popped questions over there. Okay, Stephanie asked, do you have any recommendations for a printed guideline for a cranial nerve exam for the acute speech pathologist to follow?
Yes, and the handout, I think Brooke has put in the handout up on the website with this webinar, but I made a handout for the this presentation, and I believe I included all the cranial nerve assessment tasks. I can't remember. But if not, I mean, we just pretty thoroughly went in depth with all the kind of the motor and sensory kind of tests that we should be doing. And if you want like more thorough information or maybe like a typed out handout, I'm happy to email that to you if you want to shoot me an email.
So the next question is, how do you handle doing a cranial nerve exam on a patient that has cognitive deficits and are not alert and oriented ×3?
So that's when you're really relying on the things that you can see informally. I had a patient one time who I can't remember the details, but he came to the hospital with an acute stroke. He had a history of several strokes, chronic strokes. And the acute stroke that he had was like right upper motor neuron. He had like a left central facial droop or something. And then he got really confused and what the medical team thought was delirious. And he had some baseline dementia. So like I think they were kind of contributing this like low hypoactive status to his delirium and stuff. And when I saw him, I went in and I literally just had him raise his eyebrows, like just do what I do. And the entire half of his face was not activated. And that's when I said to the medical team, have you considered doing more head imaging to maybe assess for new stroke? And he ended up having brainstem involvement. So you can do a lot of things when the patient's really just looking at you, when you can show, you say, do what I'm doing, raise your eyebrows, smile, stick out your tongue. Even if they're not doing like the depth of what we would be ideal to gain all that clinical information, you can get a lot just from informal assessment.
Definitely. And Anna, the chat is filled with positive feedback. A
Oh,
couple of questions have came in about ASHA CEUs and the certificate. So just quick recap. If you are seeking ASHA CEUs for this presentation, you will need to complete the survey. I put the survey link in the chat. It will also be sent out via Zoom emails, and then it'll close next Tuesday. So you'll have 7 days to complete the survey. And then if you want a certificate of completion, just send us an email at tims-unum@tims.com. In terms of the handout that Anna mentioned, that will be uploaded to the TIMS website with the replay. So when you go to TIMS University on demand, the webinar will be at the bottom of the page with the handout as well. Anna, do you have time for just one more question?
yeah, sure.
Okay. So hold on, I gotta scroll up because people are putting more comments in the chat. Megan asked, do you have any tips on if you are concerned for the possibility of a new CVA or neurodegenerative involvement for an outpatient where you reach out to the physician and receive pushback and a rationale the deficits are related to a past CVA?
Well, I think we always have to not overstep and to stay in our kind of realm. We always have to relate it back to the speech and the voice and the swallowing mechanisms, right? Like if we're doing a cranial nerve exam, we're doing that with the purpose of assessing the integrity of everything that needs to be functioning for adequate speech and voice and swallowing function. So if you have a patient who, let's say you do a really comprehensive cranial nerve exam and that based on what you're seeing, maybe it's just atrophy, lingual atrophy or lingual fasciculation, something that would not align with their initial stroke. You could say, based on my comprehensive cranial nerve exam, this patient has signs of potential lower motor neuron involvement, which would not be consistent with this right cortical stroke or whatever they had in the past. You always want to relate it back to what we are gathering. And sometimes when I do, more comprehensive like interviews with patients and their families, they'll mention like, yeah, and then like my right foot was hard to pick up. And I'm like, tell me more about that. So I'll relay that to the medical team. I'm not saying, hey, I think you should get an MRI of the spine because they could have compression of the spinal cord, whatever. But I'm saying just informally, when I was talking to this patient and their family, they also mentioned yada yada, which could be another factor to consider if you're trying to rule out a neurogenic process.
Amazing. Again, Anna, thank you so much for your time and
Yeah,
expertise. Everyone is commenting about how fabulous the presentation was.
thank you.
Like I said, the replay will be up on the website, and then Anna's contact information is on the screen. But if you forget, feel free to download the the handout, which has her contact information in it as well. Anna, thank you again so much, and
Of
thank you everyone
course.
for this
Thank you
spending
guys
time
for
with us
hanging
this evening.
on for a few hours with me.
Amazing. All right, bye everybody. Have a great
Bye.
night.
Bye, y'all.